right, so welcome back, healthy people, to On Call with Dr. Randy. We have Dr. Shani Woolard Clay on today's episode. Thank you for joining me.
Of course. Thank you for having me. I'm super excited to be on here, Dr. Hines. Thank you so much for your invitation. You've had some heavy hitters on this show. I listened to a few of your episodes. So Dr. Brantley and my personal gynecologist, Dr. Taniqua Miller. You've had some great folks. So I got some large shoes to fill, but hopefully I'm able to do that this episode.
I know you'll reach the bar. I know they kind of set it high, but I have one of Atlanta's best gastroenterologists with me today, so I know we'll be good on this episode.
Thank you. And before we get started, I'd also like to thank you for doing this. I know this is unpaid service that you're doing for the community, and on behalf of the entire medical field, we really do appreciate this. It's so important that our patients and that the general population really just gets this important free knowledge about their health. So thank you for taking the time out of your schedule to educate our world.
Appreciate it. You're going to make me shed a little thug tear over here.
I mean, it deserves to be recognized. You may know that the majority of doctors don't get it. So.
Right. They just want us to refill their medications and give them what they want.
Exactly. It's a different level of care. So we appreciate it. I know the patients and the listeners and your followers appreciate it as well.
Right. So what made you want to become a gastroenterologist? What piqued your interest in this field?
Sure. So I think I decided on gastroenterology. I started having an interest in it when I was in medical school. Probably around the second or third year of medical school, learning about the pathophysiology of the digestive tract and just how everything works with digestion. And I really was interested in various liver disorders and various pancreatic disorders. And when I entered residency, I made sure that during my intern year, I did a couple of GI rotations. And that's where it really hit me that was what I was destined to do. I think that I'm more so fascinated by just how amazing the digestive tract is. I love the instant gratification that I get from coming in the middle of the night and doing scopes or removing a food impaction or removing a foreign object from the body. So that really, really interests me. And so I really appreciate that about the field of GI. I do think that there's also a lot of flexibility. I think it's a good work-life balance as a gastroenterologist. So those are multiple reasons that I decided to go into GI.
There's a lot going on in the GI tract, from the mouth to the anus. Something is going on in there. So are there different kind of different specialties within GI? Like, is there a pediatric GI specialist, inflammatory bowel? What kind of different directions can you go in from GI?
So if you want to do adult GI, you do internal medicine residency first, and then you would do a 3-year GI fellowship. If you wanted to do peds GI and work with children, you would do a 3-year pediatric residency, and then you would do a 3-year pediatric GI fellowship. Within the sphere of adult GI, you can then go into transplant hepatology, where you become a transplant hepatologist and work with patients that have had liver transplants. You can also go into advanced GI, where you do procedures like endoscopic ultrasounds and other advanced GI procedures, and you work a lot with the biliary tract and the pancreas. And that's an additional year of subspecialization. So how it breaks down is, obviously, you have your 4 years of medical school, you have your 3 years of residency, you have your 3 years of GI fellowship, and then you can do an additional year of transplant hepatology or an additional year of an advanced GI fellowship. There are also inflammatory bowel disease fellowships, but those are 1 year, and people typically do that prior to entering general GI fellowship because you get so much IBD or inflammatory bowel disease exposure during fellowship. You don't necessarily need to do an additional year afterwards.
So, man, that's a lot of different routes that you can take after you've already finished your original fellowship.
It is. It is. The majority of GI doctors are general GI doctors, so like myself. So we kind of see the full gamut of things, and if there's something that's super specialized, then we'll refer to one of our colleagues at an academic GI facility.
Is there something that y'all deal with on a regular basis that some people are kind of surprised about? Like, for example, for me being a family medicine physician, sometimes people are surprised when I tell them that I deal with anxiety and depression. I'm like, yeah, I deal with that a lot. People that come to see me. But is there anything that when you tell people like, yeah, I do this every day, that they're kind of in shock about?
That's a good question. I mean, honestly, we do a lot of anxiety, depression ourselves as well, especially with patients that have things like IBS or irritable bowel syndrome. A lot of times, anxiety, depression, other psychiatric disorders can overlap with IBS. And so oftentimes, a lot of medicines that I prescribe for IBS tend to also be psychiatric medications. So things like antidepressants or anti-anxiety medications, I frequently prescribe with patients with IBS symptoms, just because of that, that gut-brain interaction is real. And when we perceive stress in our brain and in our environment, oftentimes it physically can manifest in the gut. And so yeah, that's something I see on a daily basis, the effects of anxiety and depression on one's digestive tract.
Okay. So I definitely want to have you back one day so we can talk more about IBS issues. But today I wanted to have you on so we can talk about colon cancer screening. So what I always like to do is set off for each episode having a good foundation for people to know certain things. So let's just talk about the digestive tract in general. Can you break down some of the different areas of the digestive system and what they do specifically?
Sure. So as we all know, food enters our body through our mouths. It goes down our esophagus, which is a tube that connects our mouth to our stomach. And so the esophagus works by literally allowing food to propel down into the stomach. The stomach is a structure that's connected to our small intestines, and the stomach and small intestines both work to absorb nutrients and vital elements that our body needs to function. You then have about 20 to 25 feet of small intestines, and along that tract is where you have additional various nutrients being absorbed, things like iron, calcium, etc. The small intestines then turns into the colon, and the colon is about 6 feet, 5 to 6 feet long in adults, and that's where the majority of water and electrolytes are absorbed, is into the colon. And then the colon leads to the rectum, which is kind of the end of the colon, and then stool is excreted out of the anus. So it's a very intricate system. But that's where kind of, the colon cancer screening, we look directly at the colon with colonoscopies, which I'm sure we'll get into in a few.
Right. Man, the colon is that long?
Yeah. It's about 5 to 6 feet in an average adult.
Good
You thought
Lord.
it was shorter?
That's like a little bit. I didn't realize it was like almost a whole person size laying in you, like the length of a colon.
And then the small intestines are almost four whole people. And so it's all kind of twisted onto each other and all in your abdominal cavity.
Okay. So how do you explain colon cancer to your patients?
Sure. So the majority of colon cancer comes from an abnormal growth called a polyp. So a polyp is an abnormal piece of tissue that's in the colon that can spread into the center of the colon as well as through the lining of the colon and can metastasize to the remainder of your body into, multiple organs, your brain, your lungs. I've seen it metastasize everywhere once it gets very far along. It's something that's very, very preventable, but I always tell my patients, it's important to get screened for colon cancer to prevent you from getting it. About half of colon cancer deaths in this country could have been prevented with proper colon cancer screening at the right times.
About how prevalent is colon cancer?
So about 150,000 individuals in the U.S. a year are diagnosed with colon cancer. you have about a 1 in 25 lifetime risk of getting colon cancer. And so about 150,000 people in the U.S. every year are diagnosed, and about 50,000 people die every year. So it's pretty prevalent. It's the third most common cause of colon cancer, amongst men and women, behind breast and prostate in females and males, respectively, and behind lung cancer. And it's the second leading cause of cancer death in this country. And so for it to be such a preventable cancer, it's truly a shame that it's the second leading cause of death, when there are so many tests out there and screening things that we can do to ensure that one doesn't have colon cancer, or to prevent it from happening if one does have a polyp.
When somebody is usually diagnosed, is there a particular stage on average that they're usually found at when they're diagnosed with colon cancer?
Mm-hmm. So colon cancer can be anywhere from, stage 0, which is kind of a little ditzel in the colon, to stage 4, which is a metastasis. The majority of colon cancers that we do find are earlier stages, and that's because of things like the advent of colonoscopies a few decades ago. And so when we do a colonoscopy, if we see a stage 1 colon cancer, it's pretty much a quote-unquote easy fix, right? So the overwhelming majority, more than 90% of, there's a 5-year survival rate of more than 90% for people that are diagnosed with stage 1 colon cancer. So the majority of ones that I see are early stage 1 or stage 2. I do on occasion see patients that are stage 3 or stage 4, and unfortunately they have a lower 5-year survival rate. But yes, we do typically see, and I think that there's been so much push and so much emphasis in the media with, people we've lost, like Mr. Chadwick Boseman, and with Will Smith several years ago, talking about his journey with getting a colonoscopy. There's been a lot of attention recently put on colonoscopies. And so, it really brings light and it brings awareness to the phenomena of colon cancer. So I think, as the years progress, people will be more in tune with getting colonoscopies and getting colon cancer screenings.
All right. So kind of tying in what you mentioned just now with Chadwick, did you notice more people coming in to get screened after that, or asking you more questions during visit in relationship to him?
I did. And what's interesting is that without giving too much information away about this one patient, I had a patient probably within 2 or 3 weeks of Chadwick Boseman passing, who was 38 years old, so very young. And he told me that he had been having rectal bleeding off and on for the previous few years. And I went on ahead and did a colonoscopy, and he had several precancerous polyps. And so had he waited until, the recommended age 45 now, which is the new recommendation for colon cancer screening, 1 or 2 of those polyps could have very well turned into cancer. So, I'll always remember that one patient and use the importance. Anytime an adult patient has rectal bleeding, it's in our guidelines to proceed with colonoscopy. And so, I think a lot of times, especially younger folks, will say, well, it's probably just hemorrhoids, or, I've only had it once or twice, or something to worry about. But my policy is better safe than sorry. And anytime any adult has rectal bleeding, if you come to see me, you're going straight for colonoscopy, just to be on the safe side, to make sure that there's no colon cancer that's hiding in there, regardless of how old you are once you're an adult.
Okay. Yeah, I have more people coming in on my end too, having those discussions, and want to possibly get screened earlier. They may come in and they're like 35 with no symptoms, and they say, I want to get screened for colon cancer. But how do you kind of talk to them about guidelines and what you're kind of basing certain things on? And just even sometimes like insurance won't pay for certain things, but they still want to get tested. Like, how difficult are those conversations for you?
Yeah, they are very difficult. And to your point, I had a similar situation happen to me with multiple patients after that saying they wanted to get screened. Honestly, if you don't have any risk factors, meaning you don't have a first-degree relative that had colon cancer, you don't have rectal bleeding, other risk factors include things like new-onset diarrhea, new-onset constipation, abdominal pain that, you can't figure out why you have it, Weight loss is another indication, but without any of those red flag symptoms or any of those alarm signs or symptoms, insurance honestly won't cover until you're 45 years old, won't cover a colonoscopy. I've had friends that were concerned and they paid for a Cologuard test out of pocket. Mm-hmm. And so Cologuard is a stool kit, a stool test that you mail in a sample of your stool in a cup and you mail it off. And they look for DNA or for blood from colon cancer cells. But it's hard, and I definitely understand the worry and the concern. But I just try to reassure my patients, like it's highly unlikely that you have colon cancer with no symptoms at all and with no family history of colon cancer when you're under 35. But now, if you have symptoms, it's a whole different ballgame. You're put in a whole different separate category. But yeah, with no symptoms and you feel perfectly healthy and perfectly fine, you don't have anemia, and no family history, there's really no indication to do a colonoscopy under the age of 45.
Yeah. So you kind of mentioned risk groups with increased risk factors. Are there some other groups as far as the African American population? I think the Jewish population too. Any other groups or categories increased risk?
Yeah, so definitely the African American population. I think that's because of multiple different reasons: socioeconomic factors, access to medical insurance, access to facilities where you can get colonoscopies done. And unfortunately, African Americans are about 40% higher risk of dying from colon cancer than our white counterparts. So it's a really difficult situation for our population. We all know smoking increases multiple types of cancer, but especially colon cancer. So avoiding smoking. The consumption of red meat, so high consumption of red meat throughout your life. So essentially, the more red meat you eat, the more likely you are to increase your risk of having colon cancer and colon polyps. So I always recommend, I'm not saying that you can never have a hamburger because I enjoy my hamburgers every now and then on occasion. But, not eating red meat every day, not eating red meat every week. Those are things that you can do to really decrease your risk of getting colon cancer. A high fiber diet is important as well. So lots of fruits and veggies. Making sure that you're avoiding constipation, so having regular bowel movements and really kind of getting the toxins out of your body. Those are all things that you can do to avoid getting colon cancer and increasing your risk. Alcohol use as well has been associated with potential increased risks, as well as obesity. So there's multiple things that you can do in your lifestyle to really adjust and lower your risk of getting colon cancer.
Okay. Have they figured out why for that, as obesity, why it may increase the risk? Does it have something to do with just free radicals changing DNA? I don't know if you know that, but maybe it's just some kind of correlation that they've seen with research.
Yeah, so I think it's multifactorial, right? So it might have to do with the whole free radical process. It might have to do with what you're actually eating. So if you are consuming, a lot of red meat, a lot of processed foods, a lot of fatty foods, and aren't consuming the fruits and vegetables that you should be, you're more inclined to be obese. And then that might be more of an associated risk factor as opposed to causative. So I think there's lots of different theories out there behind why obesity is related to colon cancer. We also know that a sedentary lifestyle is related to developing colon cancer. So increased exercise can help improve your chances of not getting colon cancer as well. So I think it's a complicated process. And I think over the years, we'll learn even more. But we do know some of the key things at this point that you can avoid and prevent yourself from getting colon cancer as best you can.
Okay. All right, Dr. Woolard Clay. I've been having abdominal pain for 2 days. Do I need to rush to the doctor and tell them I need a colonoscopy? How long should I kind of wait out these symptoms or go get checked out before I kind of push to get a colonoscopy or some kind of colon cancer screening?
Yeah, so 2 days, I'm not sure if you should be in a rush to go get a colonoscopy. So it really, should you see a doctor? Yes, especially if it's debilitating, like it sounds like it is for you. But it really depends. I get at least 1 or 2 messages in my inbox every day with my patients that are having abdominal pain. So, it depends on the severity. Is it a 10 out of 10 or is it a 1 out of 10? Is it associated with nausea, with any changes in your bowel movements? It really depends on the nature, on the severity, on the characteristics of the abdominal pain is how we determine what needs to be done. Now, if someone has had, chronic abdominal pain for a few weeks or a few months, we do a CAT scan, we don't see anything, then I typically do depending on the location of the pain, so whether it's upper or lower, I will do an endoscopy, which is where I take a camera and look into the esophagus, into the stomach, into the small intestines to make sure there's nothing abnormal there, and or do a colonoscopy as well, just to make sure, because colon cancer can definitely present with just abdominal pain. So it really depends on the age, on how long they've had it, on if all the other testing is unremarkable and unrevealing. Then I don't think a colonoscopy or an endoscopy for that matter is inappropriate. It would be the next step. But if someone just, came to me and I got consulted in the ER for abdominal pain, I'm not going to send them for a colonoscopy the next day. I'm going to kind of review blood work, review imaging, review their personal history, review medication use. And then, if I'm not able to find anything and they're continuing to complain of the abdominal pain, then I think colonoscopy is a reasonable option to do. But it's typically not the first thing that I do when someone comes in with abdominal pain, although oftentimes it is the first thing that people want. It's like, well, there's other things that we can do to rule out what's going on. We definitely don't always, jump straight to procedures.
Right. Anytime somebody comes to see me for abdominal pain, the first thing I'm doing is getting a pregnancy test.
Yeah. Oh, yeah.
We got to make sure that that there's no baby in there. Sometimes I get it on guys, like, we're going to get one on you too, but then they look at me crazy.
Yeah. No, that's
like, there's no baby in here. I just need to exercise. I'm like, yeah, you're right. You need to exercise.
No, it's important to rule that out first, because the last thing that you want to do with someone that is pregnant is, do a CAT scan or, something else that could potentially harm a fetus, right? So anytime you have females of childbearing age, and that's the first, they haven't already done, even if they have done it at home, I think it's still important. It's a quick, cheap test to do. So we always want to make sure, because obviously that takes you down a whole another set of issues and a whole other set of doctors if they are in fact pregnant. So I think that's
here goes some prenatal vitamins.
Exactly. And here's your referral to OBGYN.
See Dr. Miller, go over there, because that's who's going to take care of you.
Perfect person for you.
All right. Okay. So let's talk about colonoscopies. Yeah. So what's all involved with the colonoscopy? How accurate is it? Let's talk about it.
Yeah. So colonoscopies, I've done thousands of colonoscopies. I'm sure I've lost count at this point. But I think colonoscopies tend to be scary for people, just the thought of them. And literally almost every patient I have that wakes up from a colonoscopy is always like, wow, that wasn't bad. Like, can I do that again? I mean, it's not bad at all for those that have not had colonoscopies. The absolute worst part of getting a colonoscopy is the prep. So the day before, oftentimes we'll recommend like a clear liquid or like a low residue diet the day before the colonoscopy. And then you do drink prep. So we typically do a split prep, because that's what's been shown to really clear out the colon. And so if your colonoscopy is on a Monday afternoon, let's say, you'll drink half a gallon of a medicine called Go Lightly. It's just a super strong laxative. And the other half you'll drink half of that Sunday night and the other half Monday morning. Or, there's lots of other things on the market. There's things that are mango flavored and fruit punch flavored and, just different things. There's actually a pill out now called, I don't know if I'm allowed to say brand names, but there's a pill out now.
You can go ahead.
Okay, called Sutab that you can take. And so it's pills instead of drinking a big jug of anything. And so there's so many different ways to prep now. Back in the day, 15, 20 years ago, we didn't have that many options. And so now there's lots of different ways to prep and lots of different things you can take. It really depends on your insurance coverage as to what they'll cover and how much your copay will be. Some of the newer things, the pills, some of the liquid preps that are lesser in quantity are newer and tend to be a little bit pricier depending on your insurance. But either way, you can also do a Miralax Gatorade prep where you mix a lot of Miralax with a lot of Gatorade, and that helps to clean you out that night before and the day of as well. So that's the worst part.
I've heard about that one.
Miralax Gatorade. Yeah, I don't like it as
Yeah, that's the one they love the most.
The patients. Right. Yeah, because it just tastes like you're drinking a whole bunch of Gatorade. I'm not a huge fan of it. Just from an anecdotal standpoint, patients that I've had that do Gatorade Miralax don't tend to be as clean as someone that does like a Go Lightly or a Plenview or a Suprep. But, if that's all they're willing to take, then I say, okay, that's fine. Sometimes I'll even give them like double that. So I'll give them 2 doses of the Miralax Gatorade prep. But the worst part, you're literally on the toilet the whole night. So I always tell my patients, like, I apologize. I'm sorry. They always come in, they're tired, they're hungry. I'm like, I know. But, the good thing, when you roll into that OR, the worst part of your whole colonoscopy procedure is over. And that was being on the toilet all night, not being able to sleep, not being able to eat, and just feeling overall cranky and weak. And so that's the worst part of the whole procedure. When you come into the OR at my facility, we do propofol. So it's unfortunately and sadly known as the Michael Jackson drug. But we give propofol in a monitored setting with an anesthesiologist and an anesthetist present. Propofol is and I know Dr. Brantley talked about this a little bit, but it's a pretty, I love it. It's a quick on, quick off. It's like how I could describe it. So you give it to the patients within a minute or 2 minutes, they're asleep. You stop giving it to them within a few minutes, they wake up. And the sleep tends to be amazing for every patient I know that has propofol. They're like, man, that was some good. So they feel very refreshed when they wake up. So I always tell them that's something to look forward to with the sleep. For the actual propofol procedure, so once they're asleep, they don't remember anything at all about the colonoscopy. And so I take a very thin, kind of like I liken it to a garden hose. So a thin garden hose-like structure apparatus that's about 6 feet in length, and it has a camera on the end of it. And so I insert it into their colon, and I look throughout their entire colon. So I have a big monitor that's on the other side of the patient that I'm looking at throughout the entire time. And I have a technician to my left, and the anesthetist is there, and then there's a nurse. And what I'm doing is I'm looking for polyps. So I take the camera and I go all the way to the beginning of the colon, which is the cecum. And again, that's about 5 to 6 feet long. And I'm looking to make sure that there's no polyps, that there's no cancer, that there's nothing abnormal in the colon. If I do see a polyp, then I'll take it out, because polyps, as we spoke about, can lead to colon cancer, right? So polyps can range in size from 1 millimeter to, 5 centimeters. They can be quite large. For the ones that tend to be 2 centimeters or under, a general GI doctor like myself can just remove it at the time of the colonoscopy. We have different tools that we use to remove polyps. So one is a forceps. So for the smaller polyps, we just literally take a forceps and we snip it out, and then we put it in a jar and we send it off to pathology to review. We also have snares. So they're kind of bigger devices that we insert through the colonoscope that can cut off the polyp, and then we suck it through. And again, we send it off to pathology for them to look at the type of polyp that it is. For larger polyps, so polyps that are more than 2 centimeters, we'll typically send those to advanced GI doctors, and they can do different techniques where they remove them. Now, these techniques are newish. Back in the day, a large polyp had to go to surgery, right? So you had to get part of your colon taken out to remove a large polyp. But now technology and medical advances have allowed us to be able to just do a routine colonoscopy and still remove those larger polyps. So the procedure on average takes about 20 to 25 minutes. It's not bad at all. Recovery takes about 10 or 15 minutes. You're able to eat and drink freely after the colonoscopy. I typically tell my patients, hold off on maybe fried foods or greasy foods the day of the procedure. But anything else is fair game to eat and to drink after. No alcohol, so not non-alcoholic beverages because of the anesthesia, but just for that day. So overall, like I said, the most difficult part is actually doing the prep. After that, it's easy peasy. All the work is in the gastroenterologist's hands at that time, and you go to sleep and wake up like nothing happened. So it's a very, very straightforward procedure.
Okay. And that was a great explanation of what goes on in a colonoscopy. I know when my dad had his, he said he closed his eyes and he opened them. He said, when we going to get started? And they said, we already done.
Yeah, it's not bad at all. I encourage all of my patients. I try to tell them it's not. And then the thing is, too, I think that the first one is always the scariest. Like, as for any medical procedure, the first one tends to be the scariest because you don't know what you're getting into or what's going to happen. But the large majority of my patients are nervous when they roll in the OR. And then when they roll out, they're like, man, that was nothing. Like, I could do that again. So it's really not that bad. Like I said, you don't feel anything when you're under. So
yeah, they're scared. Be gentle with me. Yeah. It's my first time.
I know.
I'm scared.
You're going to use lubricant, right? I'm like, yes. That's the other thing I forgot to mention. We do use a little bit of lubricant around the scope. So at the insertion of the anus. So you really don't, you don't even feel sore afterwards the majority of times because the lubricant helps to guide the scope in.
Is there any risk involved with the procedure, like accidentally puncturing a hole in someone's colon?
Mm-hmm. Yeah. So as with any medical procedure, there are a couple of potential risks associated with it. The main ones that we worry about are the risk of bleeding, the risk of infection, and the risk of perforation. And so there's a risk of bleeding because you're inserting a foreign object into someone's colon. Same thing with infection because you're inserting something. And then perforation can sometimes happen if there's too much air blown into the colon or if physically the scope perforates. Sometimes people have things called diverticuli, which is just small little outpouchings in the colon, but it tends to be areas where the walls of the colon are thinner. And so if you're pushing a scope in and if you potentially, push through something like a diverticulum, it could potentially cause a perforation. Perforations happen less than 1 in 1,000 times. And so, I always explain that risk, but I say it's so minimal. And compared to the lifetime risk of, getting colon cancer, the benefits of getting a colonoscopy far outweigh the risks. But yes, there definitely are risks. And the main ones include bleeding, infection, and perforation. Should a perforation happen, patients just go to the hospital. Sometimes they don't require anything. Sometimes they might require, a surgery to help fix it. But again, they're so rare that they rarely happen when we're doing colonoscopy. So overall, colonoscopy is a very safe procedure, an effective procedure.
About how accurate is a colonoscopy in detecting colon cancer?
Mm-hmm. So studies have shown that it's about 94 to 95% sensitive in picking up colon cancers. Sometimes, for example, on the right side of the colon cancers can be easier to miss just because of the anatomy. Sometimes colon cancers that are flat can be a little easier to miss, and so those tend to be the ones that are missed. But overall, 94 to 95% efficacy rate for picking up colon cancer. So pretty accurate colon cancer screening tool.
Okay. So what's your second go-to for colon cancer screening? Is it Cologuard? Is it a regular, what we call a FIT test when patients send in a stool sample via a different tool? Like what's your number two?
So my number two is Cologuard. I honestly love Cologuards. So a Cologuard is a kit that you get mailed to your home, and you submit a stool sample, and it gets mailed off, and they analyze that stool sample for any signs of blood or any signs of DNA that could be related to colon cancer. Cologuard has about a 92% sensitivity when it comes to picking up large polyps and cancer, so not too far off from a colonoscopy. Now, a caveat, though, is that with the Cologuard, it is diagnostic but not therapeutic. So what that means is that a colonoscopy is both diagnostic and therapeutic. right? So we're in the colon, we diagnose a polyp or, we see a large polyp, we can remove it. So that's therapeutic at that time. With Cologuard, if your Cologuard comes back positive, meaning that something is abnormal, you would then have to proceed to colonoscopy. But for my patients that are 45 years old, no history of inflammatory bowel disease, no family history of colon cancer, no bleeding, no diarrhea or constipation, no abdominal pain, no weight loss, I'm perfectly fine with recommending Cologuard because of how accurate it is. And I'm sure we've all seen the commercials of the happy Cologuard box shown through the park with people playing basketball or holding hands in the park. So it's a very, they have a very, very attractive commercials on TV, which is good. I'm a fan of the Cologuard. I prefer colonoscopy, but Cologuard is an excellent screen test for people with zero risk factors who are also willing to proceed with colonoscopy should the Cologuard be positive or be abnormal. But yeah, I'm a big fan of Cologuard. If someone really is against getting colonoscopy, I'm not opposed at all to Cologuard testing.
Okay. And make sure you send that stool sample back to the company.
Yeah.
Do not bring it to my office. I've had somebody do that before.
You had someone do that?
Someone showed up at the front dropping the sample, like in the little cardboard thing. It didn't reach back to me, like it was some couple of layers. I'm like, no, I don't want that.
Oh,
no.
my God. Didn't read the instructions.
They need to come pick that up.
Yeah, it definitely says instructions.
You know, people don't want to. Yeah.
Oh, wow.
Right.
I actually have never.
So I like that you mentioned.
That's what you said.
So I like that you mentioned the aspect of therapeutic versus diagnostic with having a colonoscopy. Can you give a little bit of background into the business aspect, what may occur from that from a patient standpoint, and like insurance may not be covering that one after having a colonoscopy?
Yeah, so that's an issue that we tend to run into with certain insurances. You mean like once it becomes a therapeutic procedure, the patient getting charged more? Is that what you mean? Yeah. So the majority of insurances cover 100% screening colonoscopies, right? So I'm 45 years old. I don't have any symptoms at all. I just want a colonoscopy to make sure I don't have any polyps or cancer. The doctor goes in. They don't find any polyps or any cancer. I'm good for 10 years, and I don't have to pay anything. Like typically it's $0 copay. The problem comes in, well, not problem, but the issue comes in with payment when a patient gets a colonoscopy, and let's say I find a polyp, right? So I find a polyp, I have to remove it, I have to, use either forceps or the snare to remove it. I send it off to lab, and the lab has its individual charges, and oftentimes they charge by jar. So if I have, 3 different polyps in 3 different sections of the colon, I'm sending in 3 different jars. And so oftentimes pathology will charge for the jars, and then the procedure then becomes therapeutic versus just a screening. And again, it's very insurance dependent, but that is where we run into patients getting bills with some insurances. So that is something that patients should be made aware of, that, they should check with their insurance company, but they may get billed should I find something during the colonoscopy. And so I know you probably get that feedback a lot, like, you told me this was covered 100%, and now I have a $500 bill or a $200 bill. Yeah, we try to work with insurance companies too, especially if it's difficult for a patient to cover it. I don't know if I mentioned this, but I'm a physician at Emory, and we have a whole patient financial services department that will help work with patients who might have difficulty paying. But yes, we do see that happen, unfortunately.
Yeah, I've seen it happen a couple of times. Not too many, but enough for me to have it in the back of my memory when talking to patients about it.
Yeah, and it's always a drag when it happens. I wish it didn't. I wish that they covered it regardless of what was found. But unfortunately, that's the business of medicine and taken care of by people on a much higher pay grade than I am.
So, are there any blood tests that are on the market that can screen individuals for colon cancer? And if so, like how accurate are those tests?
Yeah, so the one blood marker that we typically use is and not for screening, but this is more so for surveillance, is a blood marker called a CEA. And once somebody has had colon cancer and they've gotten it treated, sometimes we'll follow that marker. So we'll check their CEA level when they're first diagnosed with colon cancer. And then once it's removed, we'll check that level periodically for the next several years to make sure it doesn't begin to rise again. But there's no good blood test that's on the market right now that is approved for being a screening test for colon cancer. So, as far as screen test goes, we have colonoscopy, of course. We have Cologuard. We have a FIT test, which is a stool sample that you would get done annually that checks for abnormal DNA in stool. We have CT colonography, which is like a CAT scan that you get. You still have to drink the prep. So you have to drink all the prep that you would for a colonoscopy. Again, that is just a diagnostic test, but not a therapeutic test. So you would it feels like a normal CAT scan to you, with the exception of having to drink the prep. But it tends to be better at detecting polyps that are larger than 10 millimeters. So should you have, 2 or 3 millimeter polyps, oftentimes the CT colonography will not pick those up. So for CT colonography, you typically get those done every 5 years as opposed to every 10 years like you do for colonoscopies, because it doesn't pick up very small polyps. And then you have a flexible sigmoidoscopy, which just looks at the left side of the colon, part of the left side of the colon, to detect any polyps. And those, again, would be done every 5 years. So the gold standard across the board is a colonoscopy because it fully evaluates the entire colon, and it's both diagnostic and therapeutic. However, for patients that, even oftentimes if there's patients who have a very tortuous colon, and I, for some reason, just cannot make it to the beginning, I might send them for a CT colonography. And at least I'll be able to rule out any large lesions that are proximal or that are before the area that I wasn't able to reach. Yeah. But yeah, again, the colonoscopy is the only diagnostic and therapeutic one.
All right. So you kind of mentioned earlier a few times talking about polyps and you sending them to the lab to see the pathologist, what kind of results they get. Mm-hmm. How long does that usually take for you to get the results from those polyps? And how much does that change your guidance as far as recommendations on when they need to follow up for another colonoscopy?
Sure. So polyps that are precancerous are called adenomas. And so adenomas are polyps that could turn into cancer several years down the line. So how we determine when a patient comes back for their subsequent colonoscopies depends on the size and the number of adenomas. So if someone has 3 or more adenomas, someone has between 3 and 9 adenomas, we typically bring them back in 3 years. If someone has an adenoma that's greater than 1 centimeter, we also bring them back in 3 years. There's new guidelines that show that if someone has 1 or 2 smaller adenomas, we can still wait 7 to 10 years to bring them back. So it really all depends on, what the polyp shows, how many there are, and the size. But typically anywhere between 3 and 10 years is when I'll bring most of my patients back. If someone has 10 or more adenomas, then I bring them back in 1 year because they're obviously at high risk of forming polyps. And if someone has 10 or more adenomas, I typically send them for genetic counseling as well, because they might have some type of syndrome that predisposes them to colon polyps and would in turn predispose them to colon cancer.
So speaking of colon cancer, worst case scenario, someone happens to be found having colon cancer. What is the treatment process after being diagnosed?
Sure. So you mean like if I find a colon cancer in someone, what I typically do is I will refer them to both a surgeon as well as a hematologist oncologist. So a colon cancer medicine specialist as well as a surgeon. I also will get just routine blood work, liver numbers checked, kidney function checked, hemoglobin, which is a marker of your blood count, checked. I'll check a CEA level, which is what we had talked about a little bit earlier. And then I'll also do a pan scan, meaning I'll order a CT of their chest, of their abdomen, and of their pelvis, just to rule out any metastases or spread of the colon cancer to any other organs. After that's done, then they'll see a surgeon and an oncologist. Depending on the stage of the depending on the stage of the cancer, the surgeon will either take them and get a partial colon resection, or they might have to do chemo first. If it's in the rectum, then it could potentially also be eligible for radiation as well. So it's kind of like a three-doctor team that works with patients that have colon cancer. And they typically get another colonoscopy after the colon cancer is gone. They'll get another colonoscopy a year after diagnosis, 3 years after the diagnosis, 5 years after diagnosis, and then every 5 years after that. So they're on a routine schedule, lifetime for colon cancer surveillance, just to make sure that it doesn't come back. And I'll also tell them to make sure that they advise all first-degree relatives that they have colon cancer, because first-degree relatives like siblings or children, or, in a rare case, their parents, if they're a younger patient, would have to be screened earlier than usual.
Okay. So y'all have gotten some great information talking about colon cancer screening, colon cancer in general, talk about risk factors, treatment options. So Dr. Woolard Clay, if you had to leave some lasting words of wisdom for those upcoming on getting screened for colon cancer, or maybe in 5 years, what would you tell them?
Eat lots of fruits and veggies. Eat your high fiber diet to reduce the risk of getting polyps and cancer, and definitely get screened when you turn 45. 45 is the new 50. That's a lot of our slogans on social media now, and that we're trying to get out there. A lot of people had stuck in their head that 50 years old is the year in which you're supposed to get your colonoscopy, but it has since been changed to 45. And so for several years, it was just 45 for African Americans, because we were the ones that were getting colon cancer early. Now it's 45 for everybody. So as of the past several months, every single person in this country, their insurance, regardless of what race they are, if they are 45, their insurance should cover a screening colonoscopy. So 45, 45, 45, not 50 anymore. And it's because we're starting to see colon cancer. For unknown reasons, we're starting to see colon cancer in patients that are a little bit younger. That's why we've dropped down the age from 50 to 45.
Yes, that diet. That's that diet playing a major factor in individuals getting colon cancer.
We're eating so many processed food. The good thing is, I feel like over the past several years, there's been this trend towards, veganism is sexy, and eating healthy is kind of, the trendy thing to do. I think about 20 years ago, I couldn't name one vegan restaurant 20 years ago. Now I can name several, especially here in Atlanta. So that's a good thing, I think. So it'd be interesting to see, over the next couple of generations, long after we're gone, if the age kind of increases and the life expectancy increases based on food. But yeah, I think a lot of it is diet. We're a very instant gratification type society, and so we like food on the run and fast food. And it just boils down to you can't get much healthy fast food. Like, there aren't many healthy fast food options, and so yeah, it's important to focus on diet, exercise, and get screened at age 45.
You eat all that fast food, you're going to die fast. That's the way I kind of look at it.
I know. It's unfortunate, but it's the truth.
So as always, we always end with Randy's random questions. Are you ready, Dr. Woolard Clay?
I think.
You're ready. I can tell by your face. Yeah. Yes. We're going to put some clapping music. Let's get it going. There we go. A little clapping going on. So you're from Maryland, correct?
Yeah, from PG County. Prince George's.
Okay. You listen to Go-Go?
What's that?
I said, do you listen to go-go?
Oh, not anymore. Honestly, I was never a big fan of it when I was in the DC area, to be honest with you. I thought it all sounded the same. So I'm sure my DMV folks are going to kill me for saying that. But since we're being honest, I was never a huge fan of go-go. But it was all that I was around when I was growing up in Prince George's County. So you don't have any go-go songs?
So y'all have a big music scene.
Okay.
No, I'm not about to quiz you on some go-go songs. Nah. I just want to know, who is your favorite artist from the DMV area?
I would probably, from the DMV area, I would probably say, so one random fun fact about me is Kenny Lattimore. Do you remember him? Yeah, he went to my high school. He's a little older than me, obviously, but he went to my high school. So I would say Kenny Lattimore or Raheem Devon. Do you know who that is?
Raheem
a lot
the
of
Dream.
people don't know.
Yes.
Remind where you're from again originally?
I'm from Texas.
Okay, a lot of people don't know Raheem Devon.
Oh man, that boy can sing. He was over here at City Winery, and I went to see him.
Yes, he was at City Winery.
He put on a show.
Yes. Yeah. I think between him and Kenny Lattimore, those are probably my two favorite artists from the DMV area.
I would do a little rendition of Raheem, but I don't own the music rights, and I don't want to be sued.
Oh, that's right.
I don't know if this microphone can
Distort
handle
your
me
voice.
singing.
Gotcha. Makes sense.
So, question number 2. Do you remember the Magic School Bus?
Yes. We used to always watch it when there was a substitute teacher in our science class.
All right. So you're on the Magic School Bus. You're going through the digestive system. Where's the place that you pray to God that the bus doesn't break down? What part of the digestive system will you be afraid of the bus breaking down?
Definitely in the colon. Definitely. We would probably die. That the smell would be so bad. We would all pass out on the bus. Yeah. I would much rather, I probably want to be stuck in the small intestines because the stomach is so acidic and the colon is so smelly. So I think a good place to get stuck at would be the small intestines. But yeah, I would definitely not want to get stuck in the colon at all. Way too dirty down there.
And if they drink some Go Lightly, it'll be straight out. You and the bus.
If they were prepping for a colonoscopy already, then I wouldn't care where I stopped at. But I would not want to be stuck in the colon if they hadn't recently prepped. Especially if they eat a lot of red meat. Definitely wouldn't want to be stuck in the colon.
All right. And the last question, what is a delta?
What is a delta? I'm a member of Delta Sigma Theta Sorority Incorporated. A delta is me. I'm a proud member. 20 years I've been a Delta. This year actually just came from Mexico week before last. With my line sister celebrating our 20-year line anniversary. So a Delta is an amazing, intelligent woman that enjoys being a Delta, enjoys all those around her. And I actually just recently joined the East Point College Park alumni chapter here in Atlanta. So looking forward to serving with them this year.
Okay, that's what's up. See, that wasn't too bad. We're going to let you off Randy's Random Question Hot Seat.
That was an interesting one. I hadn't thought about that show probably since middle school.
I know. That's where I asked Randy's Random Question. Only me and my crazy mindset would think of something like that for you specifically.
Excellent question.
All right. So is there any information that you want to share with people as far as if they want to follow up with you, maybe on social media or come see you as a physician that you want to give out?
Yeah, so my office, I'm currently down at Emory at Spivey Station. So I'm down in Jonesboro, Georgia, about 20, 25 minutes south of the city. Very easy location to find. We have a standalone building, and then we also do the surgeries or the colonoscopies right next door. And again, it's Dr. Shani Woolard Clay at Emory at Spivey Station. And my Instagram, I don't share as much medical information as I would like to, but I'm going to start doing that more. That's my goal for this year. But my Instagram is gastrodoc1211 on Instagram. So GASTRO doc 1211.
Okay. All right. So you'll go follow her at gastrodoc. What's the number again?
1211.
1211. Gastrodoc 1211. I'm gonna go follow you right now, but I appreciate you sitting down and sharing some good information for my listeners.
No problem. Thank you so much for inviting me. It's been a pleasure.